Good afternoon, everyone. My name is Dr. Benita Grassi, and today we'll be speaking a little bit about sinus augmentation. So I'll share with you guys my presentation. In 1 second. And here it is. Okay, so the presentation is called Sinus Augmentation, an Update. So which hard tissues augmentation techniques is that we know of them one of the most successful and gives the bone support for future implant placement? And the answer is maxillary sinus augmentation, specifically maxillary sinus augmentation with a lateral window approach, and has been described as one of the most successful types of augmentations we can do and bone grafts that we can do. What happens is that once we lose a tooth in the posterior sector, there's usually what follows is bone atrophy, followed then by excessive sinus pneumatization, which leads to the necessity of regenerate more bone through a sinus augmentation. The procedure has been described by the first time by Dr. Tatum in 1976, and then it was later published by Drs. Boyne and James in 1980, and has been modified and studied in depth throughout the years. Being a student at NYU, we researched a lot sinus augmentation, and it actually started history with sinus augmentation started in 1992 in the department and is still ongoing to this day. So to this day, there's still a lot of research going on regarding this kind of procedure specifically. Our database includes more than 3,000 patients and a couple of hundred of isomorphometric studies. And what we did is study to get the best result was to study the effect of time, the effect of membranes, the effect of implant surface, and the effect of different graft materials in order to make the most accurate evidence-based decision making at the end. In 1996, there was a first sinus consensus conference in which it was concluded that sinus augmentation is very, very predictable procedure. And let's see a little bit what this is about. So we have this patient coming to our clinic at NYU. We have only one missing tooth on the upper right side. Patient is fairly young, around 32 years old of age. He's male. And when we take the PAs, this is what we see. So the tooth has been missing for around 10 years at this point. So we see an excessive sinus pneumatization and bone atrophy. So we have a residual bone height of around 2 millimeters, more or less. What we did is perform a sinus augmentation procedure, place an implant, and consequently a screw retain procedure. And this is the look that we get at the end, basically. So we can see when this is the day of the insertion of the crown, we can see a little bit of blanching around the tissues, which is totally physiologic for the first few hours after crown placement, but it will go away, and the patient is aware that it will go away in the future. What happens when we have a little bit of a more difficult case, let's say? So in this case, patient is in her 50s. She presents to the clinic because she's missing the whole posterior sector and not just one single tooth. What we did is perform a mid-crestal incision over the ridge and then two vertical releasing incisions, one on the mesial side and one on the distal side. We can see the distal side is slightly more just shorter in general, and that is done to ease suturing at the end, and just because overall we don't need that much of a huge release in the back. And then what we did, once we have the whole bone exposed, what we did is to find the point of most convexity of the sinus, and we decided to go ahead and mark it with a pencil just so we know where exactly our window design should start. Once we decided that, we go ahead and we extend basically like our window design anteriorly in order to reach the anterior border, and we fill it up with xenograft large particles in this case. And this is the look after sinus augmentation has been completed. We go ahead, we place our implants, and we achieve this kind of restoration with two splinted crowns. This is just a little bit of the articles that have been published at NYU. These are the most relevant, I would say, during the years, and regarding sinus augmentation in specific. And here's the continuation of that page. And we're going to go over some of them today. There was a new sinus consensus in 2016, so 2016, in which it was affirmed again that the sinus is a very valid procedure. And not only that, it was decided during that consensus that what should be used as a graft material should be non-inductive materials and with slow resorption specifically. We came to that conclusion overall because we started studying this in 1998. So throughout these whole years, what we did was just study the different effect that different graft materials have within the sinus, and we came to the conclusion that xenograft eventually was the best one because of the slow resorption property. So despite being a very predictable procedure, there is some margin of error that can happen during the procedure. And of course, intraoperative complications happen as in any other kind of form of surgery. And those complications may include Schneiderian membrane perforation, excessive bleeding, and then reduced implant stability. And specifically, sinus infection is one of the complications that happens the least. So we would say around 2 to 5% of cases fails because of sinus infection. But at the same time, there is not a clear consensus on how to treat sinus infection. So we're going to explore a little bit of that in this presentation as well. So this presentation is a little bit to inform everyone about all the research that we have done at NYU and how to reduce and give you kind of a manual of how to reduce complications during the procedure. And all of the work that has been published that I will be showcasing today has been published in the Department of Implants, and specifically with the help of both, in collaboration of both students and faculty members together. So I'll be focusing mainly on 4 different points, and these are the key points that we need to go through in order to have a successful sinus augmentation. So we'll start with the window design. What we see here is a standard pre-classic lateral window design. So we can see that it's kind of like oval in shape, and this is what it should look like once the membrane is completely elevated. So you can see it's not attached to the bone anymore, and it's kind of like elevated completely to give space for the bone grafting material. And the previous case works very well for 1 or 2 implants, but what happens if we have more than 3 implants? So around 3 or maybe even 4 in some rare cases. So what we do is kind of like try to achieve a little bit of a more elongated shape, and that is because we want to reach the apex of each single implant, and in order to place bone graft and for them to be successful. So we would modify the shape a little bit to create this kind of more oval elongated shape. In other cases, we might have a premolar on our hands, so we have a limited mesiodistal space for both the window and the implant. So what we would do is kind of like a vertical shape window, and that is to not disturb the roots of the adjacent teeth. So we can see here we have the 2 teeth adjacent. We're not really disturbing anything because we're like very contained and very, very conservative. So we can do that as an alternative. And this has been published in 2019 by Dr. Adawi, and it's a less invasive window design for lateral wall maxillary sinus augmentation. We can see here another case. Patient comes to our clinic. When we take a PA, we see tooth is missing on upper right, and what we notice is around roughly 6 to 7 millimeters of residual bone height. So what we do is just normally go ahead, open our flap as I showed before. So always the mid-crestal incision and the 2 vertical release incisions. And what we did is apply the principle, because this is a premolar, is to apply the principle of the vertical window design that I showed you before. But we want to create some space on the anterior side to access the anterior border of the maxillary sinus more easily with our hand instruments. And what that does is basically access the whole anterior border where we know that most of the vascularization is, and that is going to be key in aiding healing and promoting the bone grafting to really adhere to patient's bone. So what we do is create kind of like this vertical J shape window design, and that's how basically we called it. It's kind of like a modified vertical. So we're still being very, very conservative, but we have that extra aid in accessing the anterior border. And what we did in this case is just open up and go ahead and fill it up with, again, xenograft bone particulate. And after that, we just go ahead and we place our implant. In this case, we placed the 4.1 parallel borders, parallel walls BL Straumann implant, and we went ahead and did our second stage, and after that, our screw retain restoration. And this case has been published again in 2024 by Dr. Tebavichulada, and it's called a less invasive window design for lateral wall maxillary sinus augmentation for single implants. There's some other cases in which we might not be able to access our sinus from the buccal side, such as in this case. So patient is 54-year-old of age. He comes to our clinic. He says that he cannot chew. That's his chief complaint, and that he would like to restore the posterior sector, basically. He informs us in his medical history that he has already received the sinus augmentation procedure years ago by a doctor in private practice, but he has never completed the treatment. So we go ahead and we take our CBCT, and what we noticed is that that's true. He did receive a sinus augmentation in the past, but as we can see, although the bone has integrated, it has not been placed, I would say, correctly, because we can see the whole palatal side is still deficient in bone. So it adhered only on the buccal wall mostly. And what we notice is that usually we would access the sinus from the buccal side, but in this case, it's very, very, very thick because of that previous sinus augmentation that had been performed. So we decided to access it from the palatal side, which is not the standard or the way we're accustomed to, but that was the only way to access it. So what we did is just visualize the anatomy very well with the CBCT and intraorally as well. And we went ahead, we performed our mid-crestal incision with, I wouldn't say release, but a little bit of a distal releasing on the posterior side, being careful not damaging any vital structures as the greater palatine artery. And we went ahead and we created a window design a little bit oval in shape in order to access the Schneiderian membrane. This is what the patient looked like at the 3 months mark. And at the 9-month mark, we go ahead, we open again, and we place our implants. So we placed one implant in the anterior side and one on the posterior side in order to create a screw-retained bridge restoration for this case. But what we can notice is that the buccal side is still a little bit deficient in bone. So we went ahead and decided to perform simultaneous GVR. So we went ahead, placed our bone graft on the buccal wall as well with our membrane, and closed everything. And when we took a new CBCT, we decided to take it also with the restoration. And what we noticed is that now the implant is completely surrounded by bone, not only on the buccal, but also on the palatal, which is a very, very good result. And this is the final result with the screw retained restoration in place. And this case has been published in 2017 by Dr. Florio in our department, and it's called the palatal window for treating an incompletely augmented maxillary sinus augmentation. The second key point I want to talk about today is the perforation of the Schneiderian membrane. So this is usually what happens basically what we see while we're elevating our membrane. We just notice this big perforation. It's pretty clear and pretty obvious to see. We just identify it as basically like a black hole. And we're faced with two different scenarios of what we should do in those cases. There's no reason to panic, but it's pretty standard. So we should still continue and perform completely our membrane elevation. And if by the end of our membrane elevation, we notice that the perforation has gotten smaller in size or stayed the same, we should go ahead and repair it in the moment with some gel foam, so with some kind of collagen foam. And we can go ahead and just continue our sinus augmentation, place our bone graft, our implant even, and call it a day basically. And that is because in the cases that we see that the perforation has gotten smaller, that means that actually the defect has been contained. And this is what happened in this case specifically. We went ahead and we even sutured a little bit of the gel foam in order to repair it, and then we went and placed our bone graft and continued our surgery. That is not always possible though. So in some other cases, we continue our elevation. What we see is that the hole just keeps getting bigger and there's no way of containing the defect intraoperatively. So what we decide to do is place gel foam again, but place it in this fashion in order to kind of repair the gel foam, to repair the membrane and just let it heal for a couple of weeks. So what we would do is basically like close everything, place the gel foam, close everything, and let 3 weeks of healing in order to create a stronger, better quality membrane. What we do is after 3 weeks, we would open the sinus again, create a split thickness flap, and just go ahead and continue our elevation as we left off during the day of surgery and the day that it perforated. What we see is, you can clearly see here on the window a little bit of irregularity. That means the membrane is very, very thick and very, very good in quality. So, which means it's very hard to perforate at this point. And that at this point, we can just go ahead, place our bone graft and implants, and continue our surgery. And this has been published by Dr. Dagba in 2015, and it's called A Novel Approach to Treat Large Schneiderian Membrane Perforation. It's a case series. The third complication that I want to talk about is the arterial bleeding. It was published by Dr. Alien about the distribution of the maxillary artery and as it relates to the sinus floor augmentation procedures. What we see is that the artery can be visualized intraosseous to the wall, the sinus wall, in 53% of cases, so almost half of the patients. And it's usually located on average at a 16.4 millimeters mark from the alveolar crest. Here we have just a view of a CBCT in which it's pretty clear to see a fairly big artery. And this is usually how it appears upon X-ray. And in this study specifically, what they studied is that the bigger the diameter of the artery, of course, the bigger is the risk of bleeding for the patient. But at the same time, it happens in less people, which is better for us and for every clinician, basically. So if the artery is around or more than 2 millimeters in diameter, the risk of bleeding, as I said, is very, very high. But at the same time, it would manifest like this in only 1 to 4% of patients. We know that, of course, if not treated properly and if not studied properly, it could be a very life-threatening and risky consequence for patients, and it requires immediate medical attention. So one of the things that is going to prevent us from having unwanted bleeding during our procedure is also know very, very well the anatomy and how the artery anastomoses within the sinus cavity. What we see here is one of our cases that we saw at NYU. We have a 64-year-old male patient. He came to NYU because he wanted implant placement on site 14, and we decided to approach him with a stage approach. So place bone graft first and then proceed with implants 9 months after. So upon taking the CBCT, the first thing we notice is a fairly big artery, as noted by the arrows. And thanks to the CBCT, we can kind of like trace the whole trajectory of the artery, so we know exactly what to expect when treating the patient, and we can plan it and to the best of our capability. For this patient specifically, we even decided to print a 3D model based on the CBCT in order to plan our surgery and exactly decide beforehand where our window design should be. And during the procedure, there was some bleeding. So although we did a lot of planning, there was still some kind of bleeding. So we decided to ligate the artery with some silk sutures. And the way we should avoid it is to plan it basically in this fashion. So we can see here, we have the drawing basically of the artery. We have ligated it. And what we should do is just go ahead and do our window design starting from above and below the artery. And then just elongate it a little bit more in order to create correct window opening without damaging the artery too much. And this case has been published by Dr. Sabater, and it's called an alternative technique to control bleeding during maxillary sinus augmentation procedure. And finally, our last but not least complication that we could have during sinus augmentation would be the sinus infection. So what we see here is a CBCT, and what we can see is two different presentations. On the left, we have a normal sinus, and we know it's a normal sinus because it's correctly pneumatized, and we can see it by the black space that is in the middle of the sinus, which is occupied by air. So in this case, the patient is completely healthy, and the membrane is looking pretty good. On the right side, on the other hand, we can see that that airspace has been drastically decreased, and that's because the membrane has taken over most of the sinus space, and that's membrane hypertrophy, which can relate in many cases with an allergic reaction. We have a similar case to the previous one, but just a little bit different because the previous one was an allergy reaction. This one is an infection after an infection after an osteotomy technique, so vertical sinus augmentation. So what we can see is the whole infection has taken over membrane has taken over the sinus space. So I want to show you this case that has presented to NYU. We have a 62-year-old female patient that presented to us, and her chief complaint is that she lost her tooth from a broken filling and she would like to replace it. The patient is ASA1, and in general findings is that we see a dentinomaxillary left first molar with a normal ridge anatomy. Also, while asking her about her social history, it's very important to note that the patient tells us that she's extremely active since her job is a yoga teacher. So she just mentions that during our medical history, we don't really think much of it, and we just go ahead with the rest of our medical history and data collection in order to get the patient to surgery. So this is prior to the surgery. What we see is tooth number 14 is missing, as said, and at this stage, the patient was still wearing a flipper. So we can see a little bit of that indentation in the mucosa due to her flipper usage, basically. We go ahead, we take a CBCT, and we plan our surgery as normal. And we go ahead, we place our implant. Procedure is very normal, very standard. We don't think anything about it. Patient comes to 1 week follow-up and she's perfectly fine. But at the 2 weeks mark, what happens is that she comes with this. So yeah, what happened is clearly an infection. And this happened at the 2 weeks mark, which was a little bit unexpected because during the first week, she was feeling pretty fine and the healing was going just as normal. But what we see here is quite a lot of edema, erythema, and we see a little bit of those large bone particles peeking through the gum. So that's just graft material, and overall swelling and pus separation. So we just decided to go ahead and drain the wound, and we can see a little bit of that pus coming out from here, and patient feels instantly better. And she tells us after draining that she has been taking her antibiotics and did everything as should, but she just returned to physical exercise a little bit earlier because she didn't think it was a problem. So after the first week, she felt actually very well, and so she just decided to resume her job as a yoga teacher. And what we think is that's what triggered actually the infection in this case. And this is after 3 months. So once we drain the wound, we decided to not explant anything. So just leave the implant in place, and we just went ahead and see what happened. And we can see at 3 months, patient is perfectly fine, and the implant is fine. We take an X-ray, and we go ahead with our second stage. Implant is completely stable and has integrated as should have. And so we just go ahead and continue with our restoration. And this is our screw retained restoration, and this is the final result. And this is an occlusal view of the final result. So what are the symptoms of a sinus grafting infection? We know that it's usually localized, but it can entail, like in the patient that I showed you before, all of the following. So swelling, tenderness, there could be a small fistula through which there's pus draining, there's flap dehiscence, so we can see a little bit of the flap actually opening, and then of course suppuration. And it's most common for it to happen during the 2 first weeks after surgery, and it gets more and more uncommon after those 2 weeks mark. So the 2 weeks are actually the most important for sinus success. And this has been published by Dr. Testori in 2002. So there's different forms of infections. There's some that can be managed only with pharmacological treatment, but it kind of depends on a case-to-case basis. And what is the pharmacological treatment for these patients? So there's 2 protocols. There's one for patients that are not allergic to penicillin, and there's patients that are allergic to penicillin. Not allergic to penicillin, they should receive amoxicillin and clavulanic acid 1 gram, or alternatively, and together metronidazole 500 milligrams. And then there's those patients that are allergic to penicillin, and they should receive levofloxacin 400 milligrams until symptoms recede. So to summarize and make it a little bit more standard for everyone to follow, we decided to kind of summarize the treatment of sinus infection in 4 different stages. So first of all, we need to reinstate or modify the antibiotic treatment. So if the patient is not taking antibiotics, he should be taking antibiotics. And if he has not taken antibiotics, then we should start thinking about changing the prescription to get something a little bit more effective for them. Second is to insert the drain as necessary. And 3 is partial or complete debridement of the graft. And 4 is total debridement of sinus cavity. So if the first step failed, we would go to the second one. If the second one fails as well, we go to the third, and vice versa, until we get to the most extreme, which would be the complete debridement of the cavity and removal of the implant, and then just start everything all over again. And these 4 steps should be repeated subsequently, and spacing more or less 7 to 10 days in between all of them. So what we made here is just an overall recap of all the authors that published regarding sinus infection and how you could treat them, and all the different pharmacological treatments and incision and drainage and all of those things that you could do in order to get rid of the infection. So as I said, again, if everything else fails, then we go ahead and we place a Penrose. So perform an incision and drainage, and then remove all the graft material that is inside the sinus. Sometimes we could see a little bit of that infection. So actually here, the bone graft has been placed, and patient is presenting the symptoms, but intraorally we cannot see much. But when taking the CT scan, that's what we see. So we see actually like a little bit of a black hole inside within our sinus augmentation procedure, so within our graft, and that would be basically the infection, and that's just gonna get worse and with time, basically. So again, the steps are incision, partial removal of grafts, then we apply a drain and prescribe patient with metronidazole, and then we always take a CBCT in order to check the sinus cavity and see that no infection has been left behind or no infected graft materials. Again, this is the patient from before. So as I said, what we did for her was incision and drainage. And this is actually the day that we removed the penrose from her, because we drained with the penrose, and we succeeded. We managed the infection pretty well. In this case, we didn't get to the third step, which would be to remove the graft material. So pharmacological intervention and IND for her was enough, but that's not always the case. So if those do not work and the patient is not getting better, then you should think about the next steps. And this is the patient again once she received that final restoration. So we're done a little bit with our complications, and what I want to show you is just this case that has been published by me and other of my colleagues and has been submitted for publication. Is just an innovative technique for maxillary sinus augmentation education. It's a step-by-step approach using 3D printed models. So let's see Elsa. Elsa is our patient at NYU. She came when she was 54-year-old of age, and she's missing the whole posterior sector. What we noticed when we took her CBCT is that we noticed right away that her sinus was kind of a modeled sinus. So it was pretty straightforward. There was no excessive bone on the buccal side, and her membrane anatomy was completely fine. So we kind of like throughout the years made her a model for our education. So we see the sinus is completely pneumatized. She has very, very little residual bone height, around maybe 1 to 2 millimeters. And this is what we could see on the CT scan. So what we decided to do is actually print models of her, and print models of her based on her CBCT. And we went ahead and with some foam, we modeled some kind of gum tissue for education purposes, and we laser cut it. And then as you can see, we kind of like engraved also the proper way of doing an incision. So mid-crestal incision with 2 distal and mesial releasing incisions. And this is what the model looked like once we remove the gum. So once we open the flap, that's what we would see. It's basically where we should start our window design. So we can see the first smaller hole is where we should start, and then the whole rest is once we basically have achieved the first hole, then we would kind of enlarge our window anteriorly, as explained. So what we wanted to achieve with this is actually a class that we gave in Italy during a conference that is called Collegio dei Docenti, that is basically held in Italy every year. And we decided to showcase this to dental students, which have almost zero exposure to sinus augmentation. So we wanted to make them feel actually what it feels like to do a sinus augmentation before doing it in a patient in the future. So we went ahead and printed everything for them, and they could actually do and play with the model and actually see what the sinus looks like and what the procedure would feel like, because it's kind of one of those procedures in dentistry that is very hard to explain and to understand at the same time while studying from a book. So until you see a video or you actually feel it for yourself, or in this case, you have a model to kind of replicate the surgery, it's very hard to understand the concept behind it and how it would work. So dental students were absolutely thrilled to do this, because it's kind of unusual in Italy, but in the US as well, to have this done while you're still in dental school. So we wanted to replicate everything, so they could replicate the incision, the flap reflection, and then just like the simulating of where they should put the window and how to enlarge it and how to elevate the membrane. So once you remove that window from bone from the window, you go ahead and you find yourself with a fake Schneiderian membrane that students can go ahead and elevate. So we brought along some hand instruments for them to kind of see. Here they completely elevated it, and we simulated some bone graft with some brown sugar. And then they can go ahead and just close our flap and just suture everything. So we would start with the 2 sutures, single interrupted sutures for all chromic cut, one on the mesial and one on the distal, the key points. And then just go ahead and suture everything else. So on the mid-crestal incision, you would mostly suture, at least us, with 4O chromic gut, and then the vertical incisions with something like 5 or 6O chromic. And then after that, you can go ahead, cut the sutures again, and then simulate kind of like a staged approach. So after 9 months, you would go ahead and place the implant, so they can actually simulate the implant placement as well. And they liked it so much actually that we are doing this at NYU every year. So when our first year students start placing implants, and start doing sinus augmentation, they actually can do that and simulate what a real sinus would feel like with the same education model that I'm presenting to you guys now. And while doing all of this, usually we like to showcase the case before. So this is exactly the case that I showed you before and how to do them. So I would show how the surgery was like beforehand, so they can kind of see what in the actual anatomy of the patient would look like. So we go ahead, mid-crestal incision, we do our window design, we elevate the membrane, we place the bone graft, and then after those 9 months, you go ahead and you place the implants. And usually when we do this, we would give kind of like this checklist to the students in order for them to follow. So they would see on the screen the patient with the actual photos from surgery, so they can kind of follow all the steps. So first thing is the incision design. They can see it on the patient, then they can replicate it on the 3D model. Flap elevation again, patient, and then 3D model, and so on. So just to recap, these would be the steps of a perfect sinus augmentation. We go ahead, we do our incision design, flap elevation, we do our window design. We create first an initial circular window, and then we enlarge it ovally. And then we check the membrane condition, we extend the window anteriorly, we elevate inferiorly and laterally. We elevate first medially. We do the osteotomy to place implants, we place our graft materials, we simulate our implant placement, we place our implant, and then we create a concave shape, we suture, and then there's those extra steps in case any complications happen during our surgery. So there's the repair of Schneiderian membrane, there's bleeding control if needed, there's incision drainage as needed, and then the post-op instructions, of course. And this is just all the sinus models that we created for that specific class that we gave in Italy, and it was around 30 of them. And to conclude everything, what I want to kind of close with is just the future directions that the sinus word could take in the future, and the things that we're currently working on at NYU. So number one, we have the surgical considerations for maxillary sinus augmentation in young adults, and how age and gender kind of influence that. Then we would have number two, the innovative management of persistent bleeding. It's a case report we're working on. Number three is optimizing implant stability in fully dentulous maxillary arches. What we're working on is experimenting a lot with the anterior border of the maxillary sinus. And number four, we're just developing more the concept of palatal window technique. So yeah, our conclusions is just that contemporary implant dentistry emphasizes the risk reduction through minimally invasive techniques. And by understanding the complexities and risk factors of sinus augmentation, we can decrease the likelihood of complications and enhance the success rates of said procedure. So that's why we want to really push with that hands-on practices and just studying everything very well beforehand on CBCTs and 3D models before to refine our surgical skills and then just replicate that in the patient. I find it very helpful, at least for my own use. And I want to thank everyone for your attention and to ICOI for inviting me to give this webinar. And if you have any emails, please, you can email me at bg2471@nyu.edu. Thank you so much for your attention.